Nurse Executive Fundamentals of the Sterile Processing Department, also known as SPD, is our topic. Rejoining us as guest for this episode is Noreen Hudson, BRG's nursing team lead for perioperative services. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Noreen, thank you so much for joining us today.
Thank you for having me.
We had you on an earlier episode, and we talked about perioperative services, and you mentioned that there were actually 6 different key components in perioperative services: pre-admission testing, pre-op, the operating room, which is what we talked about in that episode, phase 1 recovery, phase 2 recovery, and now sterile processing being the last. And you mentioned that's the most important, but yet we spent the whole time talking about the operating room. So I wanted you back to talk about sterile processing and what is it? If I'm a CNO, how do I know if I've got a good sterile processing department? Help me learn what I need to know as an executive about sterile processing.
You're right. We spent a lot of time talking about the operating room, but the surgical day starts with sterile processing. And sterile processing can be called a couple of different things. It can be called SPD, Sterile Processing Department. I'll refer to it as SPD because I'm old school. It can sometimes be wrapped in with materials management. But for the most part, when we talk about SPD, Sterile Processing Department, we're going to talk about the instrumentation management and the instrumentation housing for the operating room. So when you think of an operating room, think of all the different types of surgical cases there are, all the different specialties, all the different surgical procedures there are. Sterile processing is responsible for making sure that all the instrumentation is available for those cases. It's cleaned, it's sterilized, it's ready to go, and it's really where infection control for the surgical case begins, is right there in SPD. SPD is broken into a couple of different layers. You have your decontam, which is the department that gets the instruments back after they've been used. This is the area of SPD that washes the instruments, gets all kind of the bioburden off, the surgical burdens off. So really they're the ones that wash the instruments and get them clean, not sterilized, clean. Once that happens from decontam, they go over to the clean side of SPD. And this is where they inspect the instruments to make sure they're still sharp, there's no defects. Any instrument that has a locking device on it, it still locks. Any instrument that has teeth on it, that all those teeth have been finely scrubbed and there's no bioburden in those teeth. Once it gets inspected, then it goes over to where they prep it. So they have to put all these instruments back together in trays. Every tray houses X amount of instruments for X amount of case, and it has to weigh less than 25 pounds. When you think of what amount of instruments we use, and they're all made of stainless steel usually, that 25 pounds can add up very quickly. So now the next step after it's been visually inspected is to reassemble those trays, put all the instruments back in a categorized method into that tray. Then from there, they go to get wrapped, and they get wrapped in either a blue wrapper or they get put in what we call a rigid container, which is just a big metal container that they're organized in. And then from there, they go into the ovens, and that's where the sterilization happens. Different instruments have different sterilization processes. There's several different sterilization techniques that have to be done within SPD. So all of the staff members have to be trained on the different techniques. Every instrument has its own instructions per use by manufacturer, so they have to be very up to date on those. But once they get sterilized, that has different time cycles, different cycles depending on the instrument used. Then, when we're going to get those instruments ready to be pulled out of those ovens, it's a process that has to happen. Because as you think about when you open your dishwasher, if the drying cycle hasn't completed and you open it, you get all that condensation in your face. Now we have wet instruments, and wet instruments are dirty instruments. So we really have to do a stepwise fashion, open up those ovens and let some of that heat escape so those instruments maintain sterility, don't get wet, and we don't have what we call a wet pack on our hand. From there, we now have to move them to where they get housed and stored. So this is a very heavily regulated department. Years ago, there used to be not as many steps involved in reprocessing and sterilizing instruments or trays as there is now. So, what we've seen as the procedures become more technical, the instrumentation also becomes more technical. The labor involved in reprocessing a tray or turning that tray around now becomes more technical and more cumbersome. But we haven't done a good job as organizations in keeping up with that shifting labor demands with the labor credit per tray. So when we look at sterile processing, we look at their labor and we measure it against a couple of ways. One way is to measure it just against operating room cases. Not the best way to do it. The second way to do it is against operating room minutes. Again, not the best way to do it. The third way, and the way we like to see it done, is we like to measure sterile processing labor against instruments reprocessed, items reprocessed. Because every surgical specialty has a different tray, as we talked about a few minutes ago. And within those trays are different instruments. So one tray could take the sterile processing individual 25, 30 minutes to do that inspection, get it assembled, get it wrapped, and get it in the oven. Whereas if you have a quicker procedure, a lesser acuity procedure, a tray could only take 10 minutes. So that's why we like to look at it as trays process so we can really get a handle on what we're reprocessing, what the acuity level is, and make sure we have acuity levels built in to managing that productivity and making sure that we have that productivity tracker aligned with the steps involved. Because, like I said, it's becoming more and more steps involved to reprocessing a tray than it used to be. So we need to give a little bit more labor credits per tray than we used to.
I'm sorry, just for clarity, it is trays processed or items in the trays process that look at productivity?
So we like to go by trays processed. Now, with that being said, there are individual items that don't go into a tray. They're in what you call a peel pack. So, for example, if a surgeon needs an extra Alice clamp or some sort of clamp, we can just go and pull just that one and not have to pop open a whole new tray. So when you get into pill packs, we really like to look at how many items are you processing individually. And then we like to come up with a standard of, say, 10 individual items equals one tray.
Okay. You mentioned earlier about a weight limit of 25 pounds. Is that an OSHA requirement? Is that just for ergonomics of lifting, or is there some other reason why there's a 25-pound weight limit for these trays?
PD subscribes to a governing body called AMI, and AMI is really the ones that dictate, okay, you cannot go over X amount of weight. We want to keep it below 25 pounds for A, the safety of our staff, B, the integrity of the instruments. You don't want to have a bunch of instruments crammed in there, hitting each other, getting joisted together, because that can damage us or ruin them. So they come up with that formula that 25 pounds is the maximum, and that's where that safe zone is.
What are your thoughts around flashing equipment?
So I have had a policy in place for years now, for decades actually, of no flashing. Flashing is very much frowned upon, and flashing several years ago was changed to IUS, intermediate use steam sterilization. A lot still call it flashing though, and it's highly discouraged. Flashing is taking an instrument that got contaminated, say it was dropped on the floor, and you want to expedite the cleaning process. So you're going to throw it in the dishwasher on a quick cycle. Not always the best, because you're really shortchanging that reprocessing time frame or the reprocessing steps involved. So it is a quick way to hose an instrument off, if you will, but it's not the best way to sterilize an instrument. So What happens when someone drops it? Anytime you want to use flashing, I always encourage all of the clients that we work with to put this rule in place. You have to get authorization to flash an instrument because you have just now increased your risk of having a surgical site infection. Yeah, I want to know about it. I want to know why it happened and what can we do in the future to not have that increased risk of surgical site infection. A lot of times the room doesn't want to call the manager or director for something like that. So they'll figure out how to go about the case without it. We may have those items on that peel pack, those individual processed items that we can pool. If it's super duper critical and we have it in another tray, we can pop another tray and pull it out of that tray that's already sterilized and ready to go. Or we can figure out what we can do without it. Most times, I find that the surgical case does not get hindered or slowed down or put on pause because they're waiting for an instrument that was dropped or came back contaminated for some reason. So I always have this rule: zero flashing is the goal.
Okay. So SPD doesn't just service the operating room, though. That's probably their biggest client, but there are certainly other areas of the hospital where serial processing is processing things for procedures, whether it be in the emergency department or even for inpatient units. Is there a mix or a percentage that you normally see of amount of stuff that is coming through SPD from the rest of the hospital? Do those count towards trays or towards procedures in the productivity counts? Talk a little bit more about that.
Yeah, so you're absolutely right. SPD typically does support other hospitals, and they can even support physician offices. If you have physician offices that are doing suture removals, they can support those and have to reprocess those suture removal trays if they're not disposable. Some hospitals have also incorporated code cards into SPD to have them responsible for reassembling those code cards. Not a fan of that process. Don't agree with it. It's one of the things that we look at to move out of SPD and put into sales management side of things. But yes, sterile processing can support several areas within the hospital and outside of the hospital. And that is something that needs to be evaluated and looked at as to what exactly are they doing? How many of those items are they doing it? And are they getting credit capture for those items? And that goes back to what we were talking about when we look at the labor productivity standard. If you do only OR cases or you only do OR minutes, you're not telling the whole story on what they're really doing there because they could be supporting IR, cath lab, ER, offices. And you want to make sure that you're capturing the work they're doing for those departments in that labor standard. And a lot of times we see that get overlooked and they don't get the credit for it. So they're working harder than what the data or the productivity numbers are showing sometimes. Um, it's perfectly fine to have SPD support areas outside of the operating room. One, you want to make sure that the credit is being built to capture that. And two, you want to make sure that work stream is not taking away from your main revenue generating work stream, and that's supporting the operating room. A couple of ways you might want to do it. You might want to carve out those ancillary departments, if you will, outside of the OR and have that as be a separate subspecialty of your SPD, or you might want to incorporate that into the flow, knowing that those items are not priority items. It's really turning around that OR instrumentation that is your priority items. So there's ways to look at it and navigate it and to have it be part of SPD. It just has to fit into what makes sense as a workflow and a work stream and not take away from that main responsibility of supporting the operating room.
In our earlier podcast, we were talking about the operating room. One of the things that was talked about was cost per case. And you have some surgeons that use a lot more instrumentation than others do. So I'm wondering, as you're talking about procedures and looking at how productivity is measured on the SPD side, how does how do those two wheels fit together? Because a lap chole for surgeon A may be on a equipment side much heavier than surgeon B. And so your productivity, at least in SPD, is varying based upon the surgeon.
So you're alluding to having specialty trays, if you will, surgeon specialty trays, procedure specialty trays. It's necessary. I think what happens is a lot of times surgeons will come and say, I want this tray with these instruments in it. And then the next surgeon does that. And the next surgeon does that. And the next. So now you know, now next thing we have 1,000 plus specialty trays We're tying up instrumentation in these specialty trays that could be put into more of a generalized tray if you want, and maybe pill pack some of those specialized instruments. But you tie up inventory that could be needed, but you don't realize it because you're having it allocated to a surgeon specific tray. That wreaks havoc on inventory management. It wreaks havoc on having a increased variability in your processes, because obviously you want to reduce variability to streamline that process. And when you get into these specialty trays, that kind of disrupts that a little bit. That being said, I do think that there are some surgeons that should be granted specialty trays. But I think that goes back to, how are we rating our surgeons? Who are our ABC players? If you're an A player or a B player, I might give you your specialty tray because you're good volume, you're good with your cost, and you're good with your quality. So I might cater to you and give you a specialty tray. But if you're a D surgeon, I'm not going to cater to you because you're disrupting my work stream, you're increasing my variability, but you're not really a good steward of the operating room. So, a fan of specialty trays, I think they're necessary. I think they are very beneficial, but really you have to have it hardwired. You have to have rules and some guardrails built around it to make it worthwhile and make it fit with your operations.
Let's shift gears a little bit. In different organizations across the country, I've seen different reporting structures for perioperative services. Sometimes they roll up to the CNO, sometimes they roll up to the chief operating officer. What's the right reporting structure?
We like to see it roll up to either the CEO or the president, whichever the title is in that organization, but that senior most executive presence. The reason is this is your financial engine of your hospital. This is the revenue generating department of your hospital. You should have your finger on the pulse as to what's going on in your main financial engine of that hospital. You should also have your finger on the pulse of what's going on with the surgeons, what's going on with anesthesia. And you have to take that responsibility on the CEO level or the president level, depending on what that position is titled in that organization.
Let's assume that I'm in an organization where the perioperative services procedural areas do not roll up through the CNO. There's a dotted line reporting structure, if you will. As a chief nurse in that environment, how can I best support the perioperative services division when they don't directly report up to me? What does great support from a CNO look like in that model?
I The CNO will attend the governance meetings, attend the leadership meetings, but more as a unbiased viewpoint or vantage point that they can offer every now and then, one that can understand the nursing component of it. I've been in organizations where the CNO has absolutely nothing to do with the operating room. We go in and do the executive interviews and there it doesn't report to me. I can't give you any insight. I don't know what's going on. And that's perfectly fine because it should report to that CEO, and they're the ones that really should have their finger on the pulse.
Yeah, but is it really fine though? And the reason why I asked that question is as busy and as full as hospitals are right now, if there's not an open bed for that patient to go to that just had their hip replaced, and that's slowing up your OR, right? Because you can't
Correct.
get them out of PACU, if you can't get the patient out of the PACU, you can't get the OR patient to the PACU, and now you're backed up and you're on the table. What other things, and does the CNO play a role in surgical site infections and those type of quality aspects? I don't know. I'm genuinely asking.
Surgical site infections is something that gets monitored by most quality departments on a routine basis. And obviously, as many people know, it takes an investigation back to what is the source, what is the cause. It could have been from the inpatient side of things, it could have been in the operating room, it could have generated from sterile processing. So I think in that regards, it does take a team approach. And you're right to hit on bed management. It is a huge throughput challenge for a lot of facilities, especially as we see more and more cases come off the inpatient only list that are still being done in the hospital that require extended recoveries so they can go home that same day. That is creating a throughput issue for our PACUs, which can put the oral OR on hold, which now costs us money. So it all is intertwined and it really does take a village, if you will. So, yes, indirectly in those situations, the CNO could have input and could be a valuable asset and resource.
What role does the chief nurse play as it relates to sterile processing? If I'm a chief nurse in a hospital, how can I make sure that I've got a great sterile processing department and support them in the best way possible?
I'm glad you brought that up because I do think that our sterile processing departments are probably one of the most overlooked departments of the hospital. And that's just any hospital we go to. Because really, all issues or all concerns or all accolades generate in the OR. And we forget the behind the scenes stuff that gets that OR humming. And like I said before, it all starts with SPD. But I don't think people really realize or recognize SPD until there's a big issue. And then it's negative recognition, negative feedback. It's typically one of the most lowest paid departments in the hospital. And it's probably got the most crucial job because if I can't staff my SPD, I can't get that instrumentation turned over. I can't get that instrumentation cleaned, bamboozled in the OR. So SPD should always be in the reporting structure of the operating room, report up to the operating room manager or director, and then funnel that up to wherever perioperative services reports up to. But their relationship with the operating room is those two departments have to be together and work synergistically and be in constant communication. Did I
Great.
answer the question? I don't know if
Y-
I answered your question.
No, you did. You did.
Okay.
Yeah. When you go into a sterile processing department, we talked about productivity, but aside from productivity management and how things are being counted and credits being given, what is one top area of failure or performance improvement that you see that's needed in the processing of sterile packets?
One failure that I would sometimes see is maybe a breakdown in that decontamination process, really getting those instruments cleaned before they hit the inspection, the prep, and the cooking sterilization process. I think that's the most crucial step. It's the most undesired step because who likes to do dishes at the end of dinner? And that's essentially what we're asking them to do is wash instruments at the end of a surgery. It's a very tedious process. It's not the most desired job within SPD, but it's the most crucial one. And I think sometimes that's where I would see most of the breakdown.
And what solutions would you recommend when you see that breakdown exist?
I think it's really making sure that you have a good process in place for that inspection, that visualization. You rotate that position out throughout the day. You don't want to have that same person stuck in there 4, 5, 6 hours because I can only look at tiny threads of a teeth of an instrument for so long. So you want to make sure that you get a fresh set of eyes in there, a fresh person in there, and maybe rotate that position out and not have one person in that position ad nauseum.
Great. Well, thank you so much. I've learned a little bit more about sterile processing. I didn't know that there was a 25-pound limit, but it makes sense. And also why we really need to stay away from flashing. Any closing thoughts as we wrap up this episode?
The main components for any chief nursing officer who has inherited SPD is really get in touch with the people of SPD, find out what the culture is like and the morale is. I think that's one of, like I said, it's one of the most overlooked departments. And I think that when executive leadership rounds, they sometimes forget to go into those that depths of that hospital, the bowels of those hospitals, and go into SPD and really round and check in with that staff routinely and frequently, hear what they have to say about removing any obstacles, barriers, or challenges, really engage them in the patient continuum and the OR continuum. But just make yourself visible to SPD staff and remember that they are the heartbeat, really, of the operating room. So I think that's how a CNO can support them.
Great. Well, thank you so much for taking the time today to talk about all things sterile processing.
Thank you very much, Nick. I appreciate it.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.